Thank you very much, Alan. That's a very, very kind words of introduction. Good evening, ladies and gentlemen. It gives me great pleasure to be here with you tonight and sharing with you in the next hour or so some aspects of elder care. Specifically, we'll talk a little bit about dementia syndrome, and we'll talk a little bit about self-care. Just to give you a little bit of updated information, and I have to apologize. Maybe I sent kind of the wrong file to Alan, but since the last brief bio that we sent you, there has been some changes. I have been promoted to clinical professor, actually, in the Division of Geriatrics, and I'm now the president of the Canadian Geriatrics Society. So I was the vice president, now kind of moved on. And as well, my portfolio within the Faculty of Medicine, I'm now the postgraduate dean, the assistant dean in postgraduate medical education. So just a few clarifications in case some of my colleagues tomorrow wonder what happened to me in some of the roles that I've been doing. So I'm still doing the work that I do during the daytime. I wanted to welcome all of you. It is late Thursday evening. It's a very nice evening, I have to say. I was driving out from UBC campus. I was just sharing with Alan before, and I was going out here. I was wondering, like, how should I start this presentation? It's wonderful to see a very full crowd tonight. I guess I would start off by saying that, senior care or elder care is something which is very close and dear to my heart, and I would imagine the same for you as well. I can see that either yourself, your loved ones, or your friends, there is always someone within that category that perhaps can benefit from the discussion we have tonight. I understand the presentation tonight is going to be broken down into several sections. We're going to start out with a presentation by myself, and then there will be an opportunity for you to ask questions. And again, it is very nice to have a very intimate crowd. We can discuss things a little bit more detail. Perhaps in case you haven't had a chance to ask these questions before, this is your chance tonight. So, without further ado, that's my disclosure slide. What I would like to do is to talk a little bit about some of the changes in brain function or cognition in seniors. I'll be talking about mild cognitive impairment and dementia. I'll talk a little bit about the causes of dementia and how we make a diagnosis and management strategy. I thought that it would be helpful for us to talk about dementia and cognitive changes as an example of one of the common conditions that affect seniors. And I think this is also a situation whereby families, loved ones, friends, and other patient care supporters are oftentimes involved. In other words, we're not just treating one person who is affected by the condition, but people around that person. So I thought this is a very good example to illustrate what elder care or senior care is about. I thought I would just share with you, I actually had a clinic this morning and this afternoon, and I see many seniors from the Lower Mainland area who present with various kinds of health conditions. But this is an example, and I thought it would be helpful for me to share this with you, obviously without giving out any names to protect the confidentiality. This is actually an 80-year-old gentleman who has come in to see me because the person has become more forgetful. And this has been going on for about 3 years. The family would tell me that he has difficulty identifying family members, has difficulty taking a bath himself for at least a year, and then there's a history of high blood pressure, diabetes, high cholesterol, and he's taken a series of pills or medications. Some a diuretic, what we call hydrochlorothiazide, which is a water pill, Library-IKBLC, which is a diabetes pill to lower the sugar, a torvastatin, which is a cholesterol-lowering pill. And then we did an assessment, and I'll talk a little bit more. There are special tests that we can do to find out a little bit more about the brain function of these seniors. And the test that we do is called a mini mental state examination. It's a standard test that is done across the world, has been translated into multiple languages, and the score is marked out of 30. This particular person actually has a score which is quite low, which is 20 points out of 30. And we'll talk a little bit more about what does that mean. When I ask the person to draw a clock, I'll show you a clock drawing test and a clock face that this particular person draws. And hopefully you get an appreciation that there is something that is not quite right there. So this is actually the clock that this particular gentleman drew. You can tell that if you look at kind of the distribution of the numbers, there's a little bit off. In particular, there is actually repetition, which is not a normal. The person actually drew the numbers of 1 all the way to 12, but couldn't stop and moved on to right 13. And then when we look a little bit closer, we ask the person to draw in the hands of a clock 10 minutes past 11, and you can see that the person actually drew in the numbers 10 and 11, wrote them in, and then kind of drew the hands of a clock. So there are some abnormal findings in this clock. The reason why I want to show you and share this with you is because this is one of the very common tests that we do as the specialist doctors when we look at someone who potentially may have changes in their brain function. This person also happened to have a CT scan, also called a CAT scan, which is a computerized X-ray scan of the brain. So this is actually a cross-section of the brain. You could imagine, basically, we have the front of the person and the back of the head, and then we have the left and the right side. And you're taking a slice, obviously, only figuratively, not literally, of the brain. And you can take a look at some of the structures. The darkest part are the space that is embedded within the brain, and then the gray area represents brain matter, and then the dark area represents space, okay, or some gaps. So in a normal brain, what happens is there should be a fuller representation of the gray area. There should be more brain matter. So when the brain shrinks or undergoes what we call atrophy, which is degeneration, then you can see more black space, which means there is more widening of the normal space in between the different parts of the brain cells. So this is a degeneration change. And you can also see that sometimes in the deeper part of the brain, for instance, right around the ventricles or the space of the brain, there is evidence of tiny little white dots. Now, it may be difficult for you to see if you have to come a little bit closer, but a tiny little white dots are likely suggestive of small little strokes that have happened, what we call vascular changes or stroke type of changes. So this particular scan of the person's brain is not normal. You can tell that, number one, there's degeneration of brain matter, and number two, there likely are tiny little strokes that have happened in the brain as well. So I guess the question is, when I see someone like that, or when you experience or encounter someone like that, what do you do? I guess, your answer is, well, take them to see Dr. Wong, which is fine, But I guess, when the person comes to the clinic or comes into the hospital, what do we do? It is helpful for us to just think a little bit about what happens with aging. All of us undergo aging. We just age differently. Most people would age quite normally, and in terms of brain function, a small number of individuals would develop what we call dementia, and I'll explain to you what dementia is. And then there's also a category, a group of people who develop some changes in brain function, but they are not quite classifiable as dementia. So that condition, the in-between situation, is called mild cognitive impairment, which is also abbreviated as MCI, which is kind of the acronym for it. Now, what happened is, obviously, in people with normal brain function or cognition, their function, the physical function, is intact. Whereas, as their physical function becomes impaired, then you highly suspect whether this has evolved to becoming a dementia syndrome. So dementia is actually an illness of the brain when the chemicals become out of balance. And most likely, most commonly, it is a result of degeneration. So we'll talk about that as well. Does that make sense? What it means, therefore, is not every older person is the same. So in other words, I don't expect to see, if I run into 10 seniors, I do not expect all 10 of them would have the same kind of changes in terms of brain function or cognition. So you will have people kind of distributing all across the spectrum. Okay? It is actually a very hot topic to talk about mild cognitive impairment, or MCI. This is a situation whereby the person would subjectively describe some change in memory. And when you do some testing, you would see that there are changes that is not exactly normal. If you look at the other domains or the other areas of brain function, it may or may not be affected. But the key thing to remember is that in individuals with mild cognitive impairment, they do not have any change in their physical function. In other words, they're still able to do everything that they do normally. They will continue to walk and eat and enjoy their lives. It's just that they are more forgetful, as well as there might be some other changes. And you cannot explain these changes with a dementia kind of diagnosis. So this is a state of what we call mild cognitive impairment, or MCI. The reason why we talk about it is that this condition may predispose a person to developing dementia. We say that this is a high-risk state, okay? So what we talk about risk is a matter of probability or chance. So there is a higher chance of people as a population, as a group, in a group of people who have mild cognitive impairment, there's an increased possibility and probability that they will develop dementia, in particular Alzheimer's disease. Now, we don't actually have any evidence to say that people with MCI, this kind of very early changes kind of situation, already has dementia. At least this is what we would say in 2012. There's a lot of active research going on trying to ask the question, could this be kind of an early form or pre-form or forerunner of dementia? We don't think so at this time. Nonetheless, we do say, while you don't necessarily have to treat these people, you have to monitor individuals with this MCI very closely, because otherwise there is a risk of converting. And the risk of progressing to dementia is about 10% a year. And it's cumulative, which means in 1 year, 10% of a group of people with mild cognitive impairment may develop dementia. In 2 years, 20% of them may do so. So it is a very substantial risk. And when we suspect this is a condition, we do a special test. So I've talked about one test earlier, which is called the mini mental state exam, but there's another test called the MOCA test. And this has nothing to do with any drinks, okay? It actually stands for the Montreal Cognitive Assessment Test. So we're very proud because it's a Canadian invention. And this Montreal Cognitive Assessment Test has been translated into multiple languages as well. So what I see every day is I see a lot of individuals who come into my office, to my clinic, and asking me, you know, Dr. Wong, my loved one or myself has been more forgetful. Is this dementia? And as it turns out, a good number of them actually do not have dementia. A good number of them have what we call mild cognitive impairment. And what we do is we advise them that there is a risk of converting or progressing to dementia, but then we don't necessarily have to start treatment because there's no proven benefit of starting dementia drugs, for instance, in this population. We talk about healthy lifestyles, so physical activity is always good. Trying to reduce the risk of stroke is always important. So this is not a presentation about stroke prevention, but I'll just quickly talk about that. People with high blood pressure, you try to treat the blood pressure. People with diabetes, you try to control the sugar level in the body. People have high cholesterol, you try to lower the cholesterol level, in particular the bad cholesterol, what we call LDL cholesterol. People with irregular heartbeat, what we call atrial fibrillation, you try to thin the blood a little bit so that there is a lesser chance of blood clots being thrown off and clotting the arteries that go to the brain, etc. So that's what we talk about in terms of preventing stroke. This is what we call, in medicine, the term that we use is vascular risk modification. In plain language, all it means is preventing strokes. Does that make sense? Because this is actually an important situation, because we now are coming to terms with the reality that there are perhaps more cases of MCI being discovered, and therefore you need to kind of follow them. And as soon as you identify this progression or conversion to becoming dementia or Alzheimer's disease, then you start treatment accordingly. Okay? Now, in 2008, there was actually a study published, and it's a Canadian study. This is called the Rising Tide Study. So some of you might have heard about it. It was actually commissioned and conducted by the Alzheimer Society of Canada. And every province, every chapter actually contributed data as well. This is a graph that shows the number of individuals that are projected to have dementia in Canada. So if you see the solid line, it is kind of all the way going up from 2008 within the next 30 years, which is the next generation, 2038. The hatch line here actually represents the number of females, and the blue line represents the number of males. Now, at this point, oftentimes I get asked the question, how come there are more women who are affected than men? As it turns out, we don't think this has to do with any difference in biology. Now, clearly there are biological differences between women and men. We just believe that this is actually a survival phenomenon, meaning there are more women who survive to an older age compared to men. And therefore, and because dementia, in particular Alzheimer's disease, is profoundly a disease that we see in the elderly, this is what we're seeing. Obviously, this is currently a hypothesis. Currently, I'm actually involved in doing some research with one of my neurology colleagues in UBC, and we're looking at some of the other unexplained biological reasons why people may be more prone to developing dementia, such as in the Asian and South Asian population. So this is an area that we're actively looking at research-wise. So in 2038, we know that we are projecting that over 1.1 million of Canadians will be living with dementia. And if you look at our province, in British Columbia, there will be almost 180,000 people. And the number of projected new cases would go up. In other words, you would say that if we don't do anything, the numbers themselves speak the story. It tells the story that there are going to be more and more individuals affected by dementia. And in fact, because many of our female members are going to be affected, you can imagine the traditional role that is played by the female members in any kind of household. They are classically the care providers for the family, and so if they are affected, a lot of time their spouses also get affected because the spouses may not be as positioned or equipped looking after themselves. We know that the number of hours that are going to be spent by family members of individuals who are affected by dementia is going to be substantial. So this is not a condition just affecting the patient or the person, but rather the whole family unit as well. The most common cause of dementia, the most common type of dementia is Alzheimer's disease. However, it is also very common for us to see people who have stroke-related dementia, which is called vascular dementia, or the mixture of two things. This is called mixed dementia. Mixed because of the fact that there is an Alzheimer's or degeneration component and a stroke component, which is the vascular component. Together, they account for about 80% of the cases. Now, there are some other more unusual kinds of dementia, what I call weird and wonderful perhaps, such as dementia with Lewy bodies, frontotemporal lobe dementia syndrome, etc. Those account for about 15 to 20% of the cases. In most situations, individuals in this last category would probably end up coming to seeing me or a specialist doctor. Many individuals in the first category would still end up coming to see us, although the family doctor clearly will be the first pass, the first doctor who can help both the patient and the family. So I think this is an important slide to understand that dementia is an umbrella term. There are many different types or causes, but most commonly we're talking about Alzheimer's disease, stroke dementia, or combination, mixed. So when you look at the diagnostic criteria for dementia, in other words, who actually has dementia, how do we tell? Well, these are the individuals who have lost in their memory, and it is the sine qua non. In other words, it has to be present. But typically they have difficulty with their language, with how they talk, with their learned motions, and this is like how they use their hands. For instance, they may have difficulty putting on their dress or putting on their clothing. So I saw a patient earlier today, and the person actually has been wearing the underwear on top of regular street clothes. Now, unless it is a costume party for like Superman look-alike, I don't think that actually is considered to be appropriate. Difficulty with recognition. So a very common difficulty is misidentifying family members, thinking a spouse is actually a parent, a child is actually a sibling, and so on. And that's very common. Problem solving may become difficult. This will last at least 6 months, and then there is a loss of function. And this is where the money is. In other words, you have to document there is a change in their social or occupational function. So for instance, a person who used to be an accountant, if the person is now not able to do very simple math, that tells you there is a lot of change. And that is not just because a person is getting older. So I hear a lot of this, not just from the community, but even sometimes from healthcare providers. And that's very concerning, because a person does not develop these changes just because of normal aging. So all of these changes that I talk about are not part of normal aging. Alzheimer's disease is the most common type of dementia, and it is something that has an insidious onset with gradual deterioration. There's a progressive decline in the brain function, and in fact, this is a diagnosis of inclusion, and a doctor can use these criteria to make a diagnosis. Now, obviously, the gold standard, or in other words, the only way to be sure to tell whether this is Alzheimer's disease is autopsy. Now, we don't do that, obviously, because then you would cut open the brain and you take a slice of the brain and put it under the microscope. We don't do it. But in experienced hands, a clinical diagnosis of Alzheimer's disease can be very accurate. If you look at the literature, the numbers that people talk about in terms of accuracy is anywhere between 65% to 95%. If you talk to some individuals like ourselves who are specialists in geriatrics, we see this very often. This is our bread and butter. So we are closer to the 95%, as opposed to when you talk to individuals who don't see this very often, then they may miss the situation, then they may be a little bit lower. Okay? Is this working out so far for people? All right. So I guess when I talk about functional loss, and this is something I would encourage and invite all of you to think about for a moment. Have you encountered someone, either your loved ones or a friend, or maybe yourself, who actually run into difficulty with some of the functions that are listed on the left-hand side? These are so-called instrumental activities of daily living. Do they have difficulty with making a decision, managing their own money, driving, preparing a meal, or telephone? Now, if you have, first of all, do not panic. That doesn't mean that you actually have Alzheimer's disease or your loved one has. It's just that, these are the first kind of functions to go when a person's brain starts to show changes. By the time there are changes in the items on the right-hand side, meaning a person has difficulty taking a bath, herself or himself, getting dressed, walking around, keeping continence, which is keeping the bowels and the urine in, and has difficulty feeding. By that time, I would hope that all of you would know that there's something terribly wrong. Okay, so the question, or the pearl from a doctor's point of view, is how do you pick up these cases during very early changes? Because by the time you hit here, I think a medical student could pick up the case. I mean, no medical students around here, right? Not trying to make fun of them, but clearly it's a very clear case. But I think the difficulty is when these things start to happen, when a person starts getting lost whenever the person is driving, starts having multiple accidents or injuries in driving. For instance, a person can never find his or her own money and thinking that it must be stolen by someone else. It's a common kind of false belief that happens, and typically the person who has been accused of stealing the money, unfortunately, would be the loved ones, would be the people who are the closest to the person providing the kind of care. So these kind of situations, they are not normal part of aging. Go see a doctor right away. That does make a difference. Who tends to get Alzheimer's disease? Well, we know that Alzheimer's disease and dementia tend to happen in people as they age. So old age itself is an independent risk factor. But age is not the only risk factor. We talked about stroke already. So people who have strokes are more prone to developing dementia and Alzheimer's. Interestingly, in most situations, like we're talking about 95 to 97% of the time, Alzheimer's disease occurs sporadically, meaning it does not run in families. But there is a small cohort, about 3% and 5% of the time, of patients who actually have a strong family history. So those are called familial Alzheimer's disease. And in that case, every generation in the family tree, you may be able to identify someone who has been affected. Head trauma. This does not mean, the person as a teenager fell off a bike. It doesn't mean that person is going to have Alzheimer's disease. But I'm talking about significant head trauma, for instance, in recurrent falls, for instance, in a motor vehicle accident, or, for instance, in people who are engaged in sports activities that have predisposed them to recurrent head injury. Can anyone think of an example? Yeah, hockey and boxing. So unfortunately, if you think of the ultimate example, for instance, in terms of boxing, many boxers, including Muhammad Ali, for instance, has difficulty with dementia. Now, that kind of dementia with recurrent head injury in boxing kind of injury is actually a little bit different. It's not just called Alzheimer's disease. In the medical term, it's called dementia pugilistica. But what it is a very special kind of recurrent head injury induced dementia syndrome. Very difficult to treat. The last point is interesting. There's some study, what we say epidemiologic study, which means you look at a big population and you try to look at the numbers and you study correlations. In other words, there's not necessarily biological basis, but just number relationship. When you look at the numbers, they seem to suggest that people with postgraduate education, university level and beyond, are maybe a little bit more protective. Having said that, many of my patients are very highly educated individuals, so it is not kind of 100% true. So these are kind of the risk factors for Alzheimer's disease. Now, there has been a lot of research, and we know that when you look at the brains of individuals with Alzheimer's disease, there are chemical imbalances. And this is the topic of neurochemistry. And this is actually very interesting because whenever we teach our medical students, our first-year medical students have to learn what we call biochemistry. Biochemistry itself can be a relatively dry topic. So the way how I try to spice it up a little bit is to say, well, there's actually relevance in clinical medicine because the chemicals in the brain become out of balance in a situation such as Alzheimer's disease. There is too little of something, such as something called acetylcholine, is a chemical in the brain that is responsible for transmitting signals in between brain cells. And there might be a deficiency or shortage of another chemical called serotonin. There may be too much of another chemical which can be toxic to the brain called glutamate. So you don't need to worry about all these individual names. All I'm trying to say is there are chemical changes in the brains of individuals with Alzheimer's disease. Why do we care? Because the medicine that we give, some of them, in fact a lot of them, actually work to readjusting the chemical imbalances. If you have too little of one, you try to increase that level. If you have too much of another, you try to suppress the other one. Does it make sense? So this is kind of the basis of some of the treatments we have with pharmacologic treatments or medication treatments. So I already spoke about families, and anywhere between 2%, 3% of the time with familial Alzheimer's disease, there are some alleles. In other words, there are certain genetic makeup of a person that predispose a person to developing Alzheimer's disease. Interestingly, some of the genetic predisposition, such as the one that we talk about, ApoE4, for instance, is the same predisposition that we see in people who have blood vessel disease. Blood vessel disease are like strokes and heart attacks and so on. What I'm trying to say is there is a correlation between degeneration of the brain and blood vessel disease, strokes or heart attacks. So in the past, we used to think Alzheimer's disease is just one thing, stroke-related dementia is another thing. Now we believe they are just two ends of a spectrum. There's everything in between, what we call the mixed condition that I talked about before, and that's important. When Alan asked me to give this talk, one of the things that he asked me to do is to talk a little bit about some of the what is the hottest topic, or some of the latest research topic in the area of senior care. Well, there are many, but one of the most hot topics actually has to do with biomarkers. So these are chemicals that are found in the body that may be helpful to telling us who might actually develop Alzheimer's disease at a very early stage. Because you could imagine right now, so far, the diagnosis is a clinical one. In other words, we ask questions, we obtain a medical history, we examine the patient, we do a physical and mental state examination, we look at some tests, investigations, and then we make a diagnosis. But the question is, can there be any blood tests or special tests that you can do? Now, so far, there really hasn't been much other than some of the newest breakthroughs. So there are certain chemicals that are found in the fluid that circulates around the nervous system. This is called, the fluid is called CSF, or cerebrospinal fluid. It's a fluid that circulates, goes around the brain and the spine. So there's a space just kind of surrounding the brain and the spine, and there is water or fluid that goes around it. And this fluid may contain chemicals that are present in abnormal amounts. And these are the biomarkers. Now, you don't need to worry about remembering them. These tests are not available for routine testing. So if you go to the doctor and say, hey, yesterday I heard Dr. Wong saying about this, I want that test today, So first of all, I'm sorry they are not available. And secondly, you might want to think twice before you ask for them, because the way that you can do these tests is that you must obtain a specimen of this CSF, this cerebrospinal fluid, which actually is only available and accessible by the doctor putting a very thin needle into the spine in between the bones. So this is what we call invasive. In other words, it's not just a simple blood test. And obviously there can be complications associated with what we call lumbar puncture. Now, having said that, it's not a very unsafe procedure. Don't get me wrong. It's just that it's not a simple urine or blood test. Okay? This one, more to come. I guess if we were to talk about it again in 5 years' time, probably there will be more information. So what happens to a person with Alzheimer's disease is that over time, if you don't do anything, their level of functional performance would continue to go down. Now, many of these seniors are what we call frail seniors. Frailty refers to the presence of multiple medical illnesses or conditions, and frailty refers to the loss of physical function or the loss of brain function. Frail seniors are individuals who tend to go see the doctor a lot, and they are the individuals who tend to go into hospital a lot. And what happens is, if these frail individuals develop an illness such as a pneumonia or fracture or skin infection or bladder infection, which are very common in frail seniors, then their condition, as far as the Alzheimer's disease is concerned, may go down even faster, and they may not be able to recover. Now think about this. You may know either your loved ones, family members, or friends whom after going into the hospital, when they come out again, they were not the same again. Have you run into that experience? And somehow, things have changed. You can't pin it down and say it is because of what, but somehow they're not the same. And this is what I'm talking about, okay? A lot of times I've been asked to see individuals, and the question is, does this person have a dementia? Fortunately, in most situations, these individuals, these seniors, would come with their family members or their friends or their neighbors or parishioners in the parish or whoever it is. But occasionally, I have them arriving alone. Now that presents a diagnostic conundrum. That presents a problem, because if you ask 10 people who have dementia whether they have any memory difficulty, 10 out of 10 would tell me absolutely not, and they would tell me where to go, and it would not be home. So in other words, that collateral history, that information from other family members and other loved ones is absolutely crucial. We ask about what happens over time. We ask about what are the changes in function. So the storytelling or the data gathering or the history is absolutely essential in making a diagnosis. So specifically, what are some of the symptoms? What are the warning signs? And this is something that I get asked a lot when I come to the community and do outreach, such as what I'm doing tonight. The first issue is people have difficulty with their memory. So I'm talking about misplacing personal items, not able to remember things, not able to remember their appointments, disorientation, not knowing that the person is at home, constantly saying, I want to go home, but you are at home. No, I need to go home now. Or worse yet, have reversal of day and night. In other words, waking up 3 o'clock in the morning and say, let's go and have dim sum now. Actually, do they still have dim sum at night here in Richmond? Maybe not anymore, right? They used to many years ago. So when people used to tell me that, I wondered, are they telling me the truth? They actually may be going out to have dim sum. But poor attention span, difficulty reading or playing games. People may be very avid chess players or bridge players or mahjong players or whatever, and now they no longer can do. Or people who used to read a lot. Now what they end up doing is they still read, but it's the same page over and over again. That usually when that happens, you know that it's an issue. Word finding difficulty, people getting stuck in the middle of a sentence. Or the other one is repeating themselves. They keep saying the same thing over and over again. Now, by the time their personalities start to change, a person who is quiet now becomes more vocal, a person who is very gentle now becomes aggressive, something terribly wrong probably has happened. Hazardous behavior. People were preparing meals, now forgot to turn the burner on and left the burner on. Or people who are cigarette smokers now leave the cigarette butts everywhere in the house, almost burning the house down. Wandering behavior, leaving home and not knowing where they have gone. This is not a small issue. You might remember a couple of years ago, in fact, it was just last year, in Ontario, in Toronto area, there was a senior who was actually found frozen to death in the middle of the night. That person actually had Alzheimer's disease, and the family identified that she was gone, but couldn't figure out where she has gone. So we'll talk about some strategies. Wandering behavior is very difficult to fix. By the time they have paranoid ideas, false beliefs, seeing things, hearing voices, hallucinations, that's very abnormal. So I still have people coming into my office and telling me that their loved one, the patient, actually is seeing the deceased relatives and family members. And they thought, oh, that's because they were just too lonely. Now, it's not just because they were too lonesome. There is usually another reason. At the very end stage, people will start losing weight, have difficulty walking, and so on. So by the time these things happen, you kind of know something is wrong. Now, the challenge that we have is you have to make a diagnosis early on because there is something that we can do about it. So dementia is a very treatable condition. It's not curable, but it's treatable. And that's the important thing, because I still hear many people come to me and say, geez, Dr. Wong, why are you doing this? Why bother? They are old people, Why? To me, one of the reasons why I chose geriatric medicine as my career is because I think this is an underserved population and I want to be able to make a difference, And I think the fact that yes, these are seniors, and yes, everybody is not necessarily talking about the quantity of life, but we are very much talking about the quality of life. When we see them, we try to make sure that once we make a diagnosis, we make an early referral to the Alzheimer Society. So there is good evidence in the literature that talks about the earlier you refer the family and the support structure of newly diagnosed patients with Alzheimer's disease to the Alzheimer's Society, the more sustainable that family structure or the support structure can be. So in British Columbia, the program that we have that is run by the Alzheimer's Society is called First Link. And First Link is available in different areas of the Lower Mainland. There are lots of things that we can do and you can do as loved ones and friends and family members to supporting people with dementia. The first kind of thing would be using compensatory strategies such as NOOCs and so on. But the one I want to talk a little bit about is safety. So for individuals, for seniors who live alone, there is something called Lifeline. Has anybody heard of Lifeline? Lifeline actually is a very common service that is provided. It's particularly helpful for frail seniors, particularly helpful for people who stay and live alone. Because what happens is, if for whatever reason they get into trouble, they can just press a button either on a necklace or on a wristband, and then someone will try to call them on a telephone. And if they don't pick up the telephone after a certain number of rings, then either the family members or the police or whoever it is will be dispatched to checking out what's going on. Wandering individuals. So one of the newest strategies that I've learned from a family member of a patient of mine is that for people who tend to wander, you can actually use current technology to help you, GPS technology. So get a smartphone, put it into a non-ring, non-buzz mode, slip it into the inside pocket of a jacket for the person, and when the person is lost, you can identify that person right away on a computer searcher because it's GPS. And obviously there are multiple smartphone and services that can provide that kind of locating service. Adult daycare, support program for the patient, very helpful not just for the individual, but for family members and loved ones and friends, because you need a break, you need respite, and therefore adult daycare can be very, very helpful. I decided to just put a slide up to talk about some of the drug treatments we have available, just to show you that we actually have treatments available for individuals with dementia, whether it is Alzheimer's disease, stroke-related dementia, or mixed dementia, combining the two. There are 4 medicines that we use, and these are the names. It is actually not too important for you to know the names, but suffice it to say these are available for treatment. Obviously, the earlier or the sooner you start treatment, the better outcome it will be. None of these treatments are curative. In other words, they do not cure Alzheimer's disease or dementia, but they can be used to slow down the progression of the illness, hopefully by slowing down the change in brain function or cognition, or by maintaining the level of function, physical function that these people can do, or by stabilizing the behavior of these individuals. There's a fourth medication called memantine. It works a little bit differently, and this one is typically used for people with more severe disease, although its effectiveness may not be as strong as the other ones. In selected individuals, you may end up using combined treatments. Now, all these treatments require a prescription. You can't just go to the counter and say, hey, I want to buy some of that stuff. So you do need to see a doctor first. In British Columbia, the first 3 treatments may be subsidized by Pharmacare. So Pharmacare or the Ministry of Health has a special authority program that actually allows for some of these medications to be subsidized depending on the person's income tax levels and so on. And to apply for this subsidy, please talk to the doctor, either the family doctor or the specialist who can arrange and organize for that. I guess I'm interested as well to sharing with you whether there are any non-medicine kind of treatment and whether they are helpful in treating people with Alzheimer's disease and so on. There seems to be some suggestion that reminiscence therapy may be helpful, and this is the example of looking at old photo albums. So for instance, if you look at old photo albums and you try to ask the person, do you remember who this person is, what were we doing, and try to get some brain exercises going. It's always helpful. Cognitive linguistics, and this is the example of using music therapy or pet therapy. Memory boxes. Have any one of you have you seen a memory box? If you have been to certain long-term care facilities, nursing homes, in particular in the special care units, some of them would have a very nice glass box outside the room which features the personal belongings of the person who lives there. So, for instance, if you look at the Success Multi-Level Care Home in Vancouver, they actually have a very nice, like one of the largest memory box outside each of the rooms of special care unit. Basically, something that the person is emotionally attached to. When you use that as a prompt, as a primer, the person may be able to be stimulated to remember a little bit more. Eden Alternative is a way of restructuring the nursing home. Okay, so this is almost like the Garden of Eden, but what it talks about is a new concept of bringing in flowers and plants and pets and even babies into a nursing home, a long-term care situation to try to stimulate some activity for seniors. And then there's other education program management. Now, just in case you're wondering, if you see tiny little text at the bottom of each slide, each of these are each of the different medical publication, the literature, the paper that has been quoted for scientific reasons. So nationally in Canada, it is important for us as a country to have a dementia strategy. I guess these are the points that have been raised in the Rising Tide report back in 2008, talking about investing in areas of research of dementia, recognizing the role played by family and caregivers, recognizing the importance of prevention and early intervention. This is what we talked about already, this MCI business. Remember we talked about this mild cognitive impairment, and we talk about stroke prevention. This is what it is about. Okay? Integrating care and increased use of chronic disease prevention, and then strengthening the workforce. This is actually something that I've been working very hard at. As the president of the Canadian Geriatrics Society, my role, I'm kind of the representative of geriatric medicine for the country. So one of my roles is to try to attract more young people, whether they are doctors or nurses or other interprofessional staff, to get into the field of geriatrics in order to provide care for seniors. We have a shortage of geriatrics doctors in this country. So just to give you some information, for instance, we have approximately 250 specialist geriatricians like myself in Canada from coast to coast. We have another 200 family doctors who have extra training in care of the elderly. So in total, we have about 450 people that serve our population of about 35 million in Canada. Just to let you know, if you look at a place like Sweden, for instance, they have 500 geriatricians serving 3 million. So just to give you an idea, like we are just a fraction of what we need if you look at other developed countries. Okay, so we are short. Dementia programs. I mean, this is a very good way to sharing. If you know someone who actually has dementia or Alzheimer's, what kind of programs can you involve them in? Physical activity is always helpful. I think getting good physical health is always a prerequisite. But prevention programs as well as providing caregiver support and training. I mean, one of the reasons why I'm delighted to be invited by UBC to come out to share with you tonight is to have public forum like this, to spread the news, to spread the word, and try to hopefully dispel any of the myths that people may have. And then system navigation, this is a tough one. This is what I'm talking about is when there is a person or family who is affected, how do you help the person or the family to get the best services at the right time and in the right place? And that's not an easy question. Even for me, as someone who is supposed to be a specialist in this area, trying to navigate the system, trying to help the person to get to the services that he or she would need actually requires quite a bit of a skill. So let's go back to our case whom we saw, our friend who is an 80-year-old person. You might remember at the beginning we talked about has been forgetful, difficulty identifying family members, cannot bathe himself, history of high blood pressure, diabetes, high cholesterol, taking some medicines, abnormal clock, abnormal CAT scan. What do we do? So just to give you an idea and to wrap this up, I'll share with you the things that we can do for this person. So in this case, the diagnosis is likely Alzheimer's disease. There could be a mixed component. You talk about stroke-related dementia with Alzheimer's disease. And then we offer some home support, organize the person to have adult daycare center, refer the person to Alzheimer's Society, and we start a dementia pill, the drug that I talked about, one of the 4 things that we talked about. We treat the blood pressure, and we treat the diabetes, we treat the high cholesterol. So that's what this slide is about. So again, the bottom line is dementia is very treatable. Now, I would hope that by sharing that information with you, I've also touched on some of the aspects of the role of self-care and family or support structure for the person. I'm using it as an example to illustrate how these things are all intertwined and interrelated. So, in conclusion, we have talked today about mild cognitive impairment is not a part of normal aging. It increases the probability or risk of a person developing dementia, in particular Alzheimer's disease. The most common type of dementia, the cause is Alzheimer's disease, and then it could be also related to stroke dementia or mixed dementia. We talk about the risk factors for Alzheimer's disease: age, increasing age itself, presence of stroke, head injury, family history. Early diagnosis is important, and then some of the management strategies we can talk about using non-pharmacologic, some of the without medicines, and pharmacologic or with medicines. Okay? So with that, I will pause and invite any questions and comments. Thank you very much. Sure. Yeah. Okay. Yes.
An Alzheimer dementia because the doctor stopped the cholinesterase.
Okay. Sure. The pill. Yes. Sure. Sure. Let me repeat the question so that everybody can hear. So the question here is the lady's father actually has been diagnosed with dementia and has been diagnosed with stroke-related dementia, also called vascular dementia. How do we know this is a pure stroke dementia and not like a combined? Because the person was started on the treatment, one of the pills that we talk about, something called Aricept or donepezil, and that has been stopped by the doctor. So my answer is this. It is very difficult to say whether someone has pure Alzheimer's disease or pure stroke-related dementia, because in many situations, the person may have both, so-called mixed dementia. My other point that I would say is there is good evidence to support the use of these pills, dementia drugs, such as the one that you talk about, in patients not only with Alzheimer's disease, but also with stroke-related dementia. Which means even if we agree the diagnosis is a pure stroke-related dementia, there's still ample reason for us to consider using cholinesterase inhibitor drug. So I would advise in this situation, without seeing your dad, it's impossible for me to give specific medical advice, but I would say perhaps it's an opportunity to go back to talk to the doctor and maybe consider referral to a specialist, and then we can talk about that in more detail. Okay? Yes?
I think most of us are very impressed with your knowledge and experience. But if you know someone who needs your service, what are the things that you can do so that that particular person can reach you?
Sure. So in British Columbia, to access the service of a geriatrician, a geriatric specialist, you need a referral from the family doctor. So the family doctor will be able to refer and either to myself or to any of the specialists in geriatrics. And then depending on the geographic area where the person lives in and whatever, there might be different choices. So I think in British Columbia, we are fortunate. We actually have a good number, even though we are short, but we still have a good number of geriatricians to start with. So go through your family doctor. You can explain to him or her that you have heard this talk by this Wong guy, and maybe you want to go and see one of the specialists. Not trying to draw business for myself, but to be very careful.
What happens if the GP refuses to send the person to a specialist?
The question is a very good one. What happens if, for whatever reason, the family doctor does not agree with a referral to a specialist? I've been asked this question many, many times in many public forums. All I can say is two things. Number one, it is important to get the family doctor involved and on side when we are delivering treatments, because ultimately the specialist will only see the person maybe every few months or so, but the quarterback person is still the family doctor. So that's number one. Having said that, the system that we'll talk about navigating the system says that you need to have a family doctor making a referral. I emphasize and underline the word a family doctor, so you can interpret that. Yes?
Is it okay to switch from one specialist to another?
Is it okay to switch from one specialist to another? I guess the question that I would ask is, what is the reason for the switch? So, language, I see. So I would say oftentimes it is, the doctors understand if for whatever reason the person or the family want to go from one doctor to another one. That's perfectly fine. I mean, for me, for instance, my practice is in the Vancouver General Hospital, and I see a lot of people from the entire Lower Mainland. So sometimes after seeing them a few times, they say to me, Dr. Wong, we'd love to come back, but I live in Maple Ridge, so how on earth can I come out to Vancouver, to VGH to see you all the time? And I'm perfectly happy to refer the case back to another doctor there. So I think similarly, I think the doctors will be okay. I end up seeing a lot of people for second opinions for whatever reason. In other words, people have been make the diagnosis, but for some reason they heard about me and then they figure out, geez, we wonder whether this was the right answer. So I end up getting a lot of referrals in, and that's okay too.
Dr. Wong, we have a live webcast question.
Yes.
It's from Leanne. Leanne from Vancouver. Her question is, does food and diet help prevent dementia?
Okay. So that's a very good question, Leanne. What I would say is there is no concrete evidence that any particular kind of food or diet can actually be effective in preventing dementia. There was some study, and this is quite a few years ago, that talk about vitamin E, for instance. So if people take vitamin E, perhaps that can be protective for dementia. But that particular evidence didn't quite pan out. There was another suggestion that ginkgo biloba, which is an extract from the ginkgo root, in high extract form, there was some suggestion it could slow down early Alzheimer's disease. Unfortunately, that did not pan out because there was a randomized control trial that was done in the United States, published in JAMA, Journal of American Medical Association, a few years ago. That was a negative study that said ginkgo biloba extract did not actually help to slow down or prevent dementia. So by and large, my answer is no. Unfortunately, there's no particular food or dietary intervention that can be helpful in preventing dementia. Now, having said that, remember, anything that prevents stroke can be helpful, because we talk about stroke is bad for dementia. So there are certain kind of dietary habits that can be helpful to preventing strokes. So for instance, the classical example that we talk about is the amount of salt intake or sodium intake, right? Because we know that salt intake and sodium intake, when in very high amounts, in particular in people with high blood pressure, hypertension can accelerate the high blood pressure. And high blood pressure can increase the risk of stroke, which in turn increases the risk of dementia. So in an indirect way, healthy, balanced diet can be helpful. Yes.
Same question on diet. What is your take on
Coconut
coconut?
oil. You probably have read some of the newspaper kind of articles on that. There is no conclusive evidence that coconut oil per se can actually be helpful in treating or preventing dementia at this time. And again, in kind of the way Western medicine is practiced, we always have to look at the quality and the quantity of the evidence from clinical trials. The other thing that I would say is you have to be a little bit careful with coconut oil because it is very high in saturated fat, and in particular triglycerides. So in people, which is a form of fatty acid chains, in people with high cholesterol levels, a high amount intake of coconut oil can be in fact detrimental in terms of increasing the lipids further, therefore increasing the risk of stroke and so on. We talked about that already. Yes?
Can you comment on inflammation and anti-inflammatory drugs?
Absolutely. Absolutely. This is a high-level question. This is very good. There seems to be some interest to ask the question, is there an inflammatory component in the pathogenesis or disease formation of dementia, including Alzheimer's disease? And preliminary evidence in animal models would suggest there likely is an inflammatory pathway that is involved. But I underline the word in animal models. There's no definitive human studies done to date to demonstrate that. Interestingly, because of that theory, the question is if you give anti-inflammatory drugs, such as non-steroidal anti-inflammatory drugs, or what we call NSAIDs, example, ibuprofen, if you give something like that, can you prevent or slow down dementia? So people have looked at epidemiologic studies, which is big population studies, and the evidence was kind of in between. It was not clear. Then people proceeded to do randomized control trial, clinical trial evidence, and the clinical trial evidence was definitive. It was negative. So in 2012, our recommendation is there is no proven evidence that anti-inflammatory drugs can be used to treat dementia. So that's it's long with that answer, but that's the answer. Yes?
In connection with preventive measures, you have talked about food, and then you also have talked about physical exercise.
Yes.
So is it acceptable to say that if someone who is in difficult relationships in the family or with social relationships, even putting in more simple terms, someone who is unhappy would likely to suffer damage of the brain?
A good question. Is there another way of asking the question is there any kind of relationship between emotional status and family dynamics and the development of dementia? So the straightforward answer is no. There's no direct relationship except for the following observations. In early dementia, it is common to see symptoms that look like depression. So in other words, major depression or a low mood state can be an early mimicking kind of symptoms in people with early dementia. So there's overlap. Number two, we do know that in individuals who are affected with Alzheimer's disease or dementia, their family members and their loved ones, the support structure, oftentimes experience significant stress. So caregiver stress is very substantial. And as a result, that can influence on the family dynamics and relationship, which means people get unhappy. And as people get unhappy, their way to cope with the dementia also goes down, which means they get even more stressful. So it's a vicious cycle. So I see a lot of that. A lot of my work actually has to do with trying to help the family and the person involved, affected by Alzheimer's disease, to sort things out without necessarily putting myself into the family situation because that would not be appropriate. Nonetheless, referring resources or support structure potentially for the family. Yes.
I am a caregiver.
Yes.
I need some points to do how to manage dementia-related case with a client. And I read one in the magazine, management of food, that you have to give more carbohydrates or more protein and giving food in a regular time would help the client well and what I mean, in a well condition.
Sure. So let me just repeat the question briefly. I guess the question is about, is there any evidence or truth to providing meals to individuals with Alzheimer's disease, maybe a different dietary content, more carbohydrates or protein, etc., or like the timing of delivering the food and so on. From a caregiving point of view, I think one of the things that will be most helpful for all of us when we're working with individuals with dementia, including Alzheimer's disease, is routine. So the moment you set up a routine, that is going to be most helpful. So in fact, if I have to find a magic word for the family and caregivers in patients with dementia and Alzheimer's, I would say the word routine. So whatever the routine is, do the same thing over and over again, because the person can then expect what to receive. There's no evidence to support any change in the protein content or the carbohydrate content or the fat content of any food having anything to do with progression of the Alzheimer's disease. So in other words, the food content per se does not matter. However, I think it is helpful to develop that routine of administering food at particular times so that people actually know what to expect, and that is helpful. Sure. Yes. Sure, I'll translate that. Sure. Okay, so the question is about alternative medicine. For instance, hyperbaric oxygen, which is high oxygen supply, acupuncture, etc. Can they be helpful in the treatment and prevention of dementia, in particular given the costs that are involved? This is a common situation that I face. I've been asked whether these treatments or any other kind of alternative treatments can be helpful. There is no proven evidence in the medical literature to support the use of these alternative treatments in preventing or slowing down the progression of dementia. Specifically, in terms of hyperbaric oxygen, there is no evidence of that. In terms of acupuncture, this is interesting. Acupuncture can be helpful, and in fact, we also use acupuncture as the principles in people who have particular kind of musculoskeletal problems, in other words, bone and muscle and joint related problems, but not specifically for the dementia. Okay? And then there have been other questions that I've been asked, just to give you some idea. People who actually have been told that there's different cocktail therapies, which does not work, by the way. Or sometimes I've been asked the question, animal brains, and no, they absolutely do not work, so please don't eat them. Eating walnuts, the shape of a walnut looks like a brain, but no, that does not help. So I may as well say that. I've been asked playing mahjong, does that help? I think that helps to socialize, but that doesn't help to stimulate enough brain activity per se. Mind you, I do not discourage people to do that, simply because I think socialization is a very important component in maintaining the quality of life in people with dementia. Okay.
Age 60, after this hyperbaric oxygen treatment, apparently her condition improves significantly. Once the treatment stops, goes back to
Right.
Is that blurry effect?
Yeah, I think the question about, when someone receives hyperbaric oxygen, transiently may show some difference and then afterwards doesn't show. I think the difficulty here is we must look for concrete evidence that is based on large-scale, properly conducted clinical studies. And in individuals like N of 1, like one particular person may work and another group of people do not work, we have to be very careful in terms of the advice that we give. So at this time, we say there's no evidence to support the use of hyperbaric oxygen. Yes.
In fact, people with family history, what is some of the tips you would give to family members to suggest? First of all, does the GP tell the person what causes the dementia? And is it possible for the children or the family members to be
Yeah, that's a touchy topic. So the question is about familial Alzheimer's disease. How do you manage, how do you approach that? So first of all, I would say in individuals who are suspected to have familial Alzheimer's disease, that's 3% or so that we have talked about. In other words, in the pedigree, in the family tree, there's every generation is affected, at least one person. I think that person should be referred to see a specialist. I think, first of all, this is not primary care anymore, this is specialist care, because we can do genetic studies and counseling. That's first of all. Secondly, let's say you identify and confirm a case of familial Alzheimer's. What can you do? The treatments we have available are only effective in people who already developed the dementia. And yet, if you say someone is at risk or increased risk of developing, starting the treatment early does not help. In fact, the potential side effects would outweigh the potential benefits, which means it becomes a very difficult situation. So it involves what we talk about a bioethical principle of, like, when you screen, when you look for this kind of thing, and you find out what are you going to say. Because if you say, what are you going to do? If you don't do, why on earth did you look in the first place? So this becomes a very ethical kind of discussion, and we could spend another hour here, which I won't do, don't worry, talking about the pros and the cons of that, because that's a very tough one. Thankfully, we don't see that very often.
All right.
Yes.
How about this depression is could lead to dementia?
Okay, so let me just clarify the relationship between depression and dementia. Depression itself does not lead to or cause dementia. Depression, however, can be seen commonly in individuals who develop early dementia. In those situations, if you treat the depression, the mood may improve, but the other symptoms, including memory, etc., may continue to deteriorate. That is how you can tell this is not just a depression, but it's an underlying dementia as well. So the two are related, but it's not one causing the other. So I hope they clarify that, because that's very important. Because mood disorder, such as major depression, is common in our society. And in particular, many of the symptoms may mimic that we see in early dementia.
Yes, doctor, because I have a client that is an elderly and 98 years old, and she's not diagnosed of dementia, but she has mood disorder.
Yes.
And she's taking a mild antidepressant, and still she has some psychotic behavior. I cannot say this. It's really very hard for me to handle because of her old age. So
Right. So you're talking about an example of a senior person who has some depressive symptoms and some behavioral issues, and difficult to handle from a caregiving point of view. I think my advice in general, again, I cannot give specific medical advice because I haven't seen the person, but in general, I would say this is someone who probably should be referred on to see a specialist, probably a geriatric psychiatrist. So I'm a internist geriatrician, I'm not a psychiatrist, but a psychiatry specialist who look after seniors. I think probably a geriatric psychiatry specialist will be helpful in a situation like that. I think a specialist may be helpful.
More questions?
thank you.
Okay.
Thank you, Dr. Wong, for a wonderful
Okay. Thank you.